Hello, in today's class we will discuss about peripheral ulcerative keratitis. So, what is PUK? So, PUK is destructive ulceration of peripheral cornea with a typical overhanging progressive edge and limbitis. So, this is a definition of peripheral ulcerative keratitis. So, under this we have the etiology. So based on what causes peripheral ulcerative keratitis, we can divide it into autoimmune or infectious causes. Okay. So this is a diagram of PUK. So there is a autoimmune diseases. We can have autoimmunity to either corneal antigens such as in Moorens ulcers, which we will discuss in detail at the end of the class, and systemic vasculitis such as rheumatoid arthritis, which is the most common cause of PUK identified, and granulomatosis, polyarthritis nodosa behçet, SJS, etc. So coming to infectious, we have either systemic or ocular infections which can predispose to PUK, such as hepatitis C, salmonella infections, and HSV, HZV, and fungal infections, Helminth infection. So these are the etiology of autoimmune or infectious conditions which lead to PUK. Now coming to the pathophysiology. So in autoimmune conditions, so what happens is that the peripheral cornea is different from the central cornea. So what the difference in the peripheral cornea is that it is a highly vascular structure, it receives blood supply, thus there is more chance of getting antigens and antibodies over there, and it has rich lymphatics. So there is more inflow of immune mediators, and along with that it has densely packed collagen. So any collagen vascular disorders can manifest over here, right? So this is the special qualities. So these predisposes it to inflammation following any trivial trauma or infections and all, right? So this causes inflammatory reaction at the peripheral cornea, which leads to immune complex deposition and complement activation. So because of this, there is immune mediated vasculitis, which ultimately leads to increased vascular permeability and increased cytokine and increase in neutrophils in that area. So what do these do? So we have interleukin 1 and neutrophils TNF alpha, which is being liberated. So this cause proteolysis and collagenolisis and activate matrix metalloprotease. So this leads to the destruction of corneal stroma. So this was regarding autoimmune. Now leading to infectious cause, the microorganisms they produce proteases which disrupts the extracellular matrix. So this in turn leads to the cytokine release, which leads to recruitment of neutrophils at that area from the peripheral part of the limbus to the peripheral cornea, right? So these neutrophils again they lead to the same mechanism, that is proteolysis, collagenolisis, MMP, and finally leading to the destruction of corneal stroma. So this can ultimately lead to corneal perforation, and superinfection is a possibility because of reduced immunity. So most commonly with Staph aureus and Pseudomonas aeruginosa, there can be a superinfection. So these are the complications, right? Corneal perforation, superinfection, severe astigmatism, and secondary cataracts and glaucoma can occur primarily due to inflammation and also due to the side effects of corticosteroid use, that is the treatment related side effects. Now coming to the lab investigation. So we have to rule out the systemic pathology in these cases with the help of CBC, ESR, CRC, and RA factor, which is positive in rheumatoid patients, anti-nuclear antibody assays for various other collagen diseases, and chest X-ray for sarcoidosis, tuberculosis, and vaginal granulomatosis. Now coming to the treatment part. So we can divide it into medical and surgical therapy. In medical treatment, we have to give prophylactic antibiotics, that is topical antibiotics, and lubricants, because in the early cases there is a neoadjuvant disease, and topical collagenase inhibitors, the examples of which include sodium citrate 10%, acetylcysteine 20%, and methyl medroxyprogesterone, that is 1%. Then we should also give topical corticosteroids. So this can be given as an initial therapy in mild and unilateral cases, whereas in severe cases or the ones in autoimmunity, we have to give systemic corticosteroids, because topical corticosteroids can lead to the progression of the disease and enhance the perforation, okay, because the cornea is already very thin, right? So this was regarding systemic corticosteroids. Yes. So we have to give oral prednisolone 1 mg per kg per day, and in case if it is progressing, then we have to add pulsed methylprednisolone 0.5 to 1 gram per kg per day for 3 days. Now, next group of drugs is systemic immunosuppressants. So these include methotrexate, azathioprine, cyclosporin, tacrolimus, mycophenolate, mofetil, cyclophosphamide, etc. Okay, so when are these indicated? So in case of very lethal systemic vasculitis, or if there is some ocular manifestation such as necrotizing uveitis with or without vasculitis, and bilateral or a progressive Moorens ulcer, which we will discuss in some time, and if the patient is unresponsive to medical or surgical therapy, then we have to add systemic immunosuppressants. The cyclosporin A is the preferred drug for idiopathic PUKs. Okay, so cyclosporin A is for idiopathic PUKs. In case of PUKs with systemic vasculitis, we have to give cyclophosphamide with corticosteroids as first line therapy. Okay, and for the maintenance, we can give oral or subcutaneous methotrexate. Now coming to the other group of drugs, that is biological agents. So these include anti-TNF alpha agents and the antibodies, okay, monoclonal antibodies. So this treatment is a time-taking one. So even after the regression of the ulcer, we have to provide treatment for 6 months to 1 year. Okay, so the examples of biologicals include etanercept, infliximab, adalimumab. Coming to the surgical treatment, we have conjunctival resection. So this helps in 2 ways. So one, by reducing the limbal source of these cellular mediators of immunity, autoimmunity, right? And it can also help for the purpose of biopsy. Okay. Then we can perform in case of perforation or impending perforation, we have to perform patch graft if the defect is small, that is around more than 5 mm. In case of small defects which are less than 2 mm, we have to give tissue adhesive such as cyanoacrylate glue. The defect is less than 2 mm. Okay. Then the patch graft can be either commonly with amniotic membrane graft. And in the rehabilitation, we have to perform lamellar tectonic graft and with or without a central penetrating keratoplasty. So the tectonic graft is the one which is given to support the cornea. Okay. So in case of small peripheral ulcer, we can take a crescent-shaped lamellar graft. Or in case of circular concentric ulcer, which is not involving the central 8 mm of the cornea, we can perform a donut-shaped lamellar graft. So grafting with amniotic membrane is also done. So this was the treatment of PUK. Now coming to what is Moorens ulcer. So Moorens ulcer is a idiopathic PUK without scleritis. Okay, this is very important. There should be no scleral involvement. So coming to its definition, it is a crescent-shaped, painful, destructive inflammation of marginal corneal stroma, sparing the sclera. Okay, so this definition encompasses all the features which Moorens ulcer should have. Okay, first is that it is highly very painful, it is sparing the sclera, and the third one is it is idiopathic, that is there is no other cause or systemic disease which can be associated with PUKs. Alright, so in this, the pathogenesis has been identified as antibodies to cornea specific antigen, that is calgranulin C. So it is labeled as COAG. And in cases with genetic predisposition, HLA-DR17-3 and HLA-DR2 have been identified. So the triggering factors for this include trauma, prior surgery like cataract surgery, prior infections like with helminth or hepatitis C infection. Now coming to vaccine criteria, there are 5 things which are there in the vaccine criteria. So first one is that to diagnose it as a Moorens ulcer, it should be a painful crescent-shaped peripheral ulcer, and there should be extensive undermining of the central edge of the ulcer. Along with that, there should be dense corneal infiltrates at the leading edge. There should be no scleritis and no systemic disease. Right? So these are the 5 things which are there in vaccine criteria to diagnose a Moorens ulcer. It is a painful one, crescent-shaped one in the periphery of the cornea. Number 1. Number 2 is extensive underlining of the central edge. There are infiltrates, no systemic, and no scleritis. Now coming to the types of Moorens. So the first one is unilateral or typical or benign Moorens. The other one is bilateral, atypical or malignant. Bilateral can be indolent or aggressive, right? So unilateral, typical benign is slowly progressive, occurs in the elderly and is a good response to treatment. Whereas the aggressive one is seen in younger individuals, it is bilateral, destructive and needs maximum immunosuppressive, and there is more chances of perforation and all in this aggressive cases. Okay, so perforation can occur with minor trauma in almost 30 to 40% of the cases. Coming to differential diagnosis, we have pellucid and teres marginal degeneration, in which there is no pain, no inflammation, no scleritis or iritis, right? And the epithelium is intact. And the treatment is similar to that of PUK as we have discussed earlier. Thank you for watching. Bye bye.